Hello, everyone, and welcome to ADDitude Magazine's ADHD Experts broadcast. We are pleased to have Dr. Theresa Cerulli here to talk about treating complex ADHD, diagnosing and managing comorbidities in concert with ADHD symptoms. Before we get started, let me note a couple of housekeeping items. Those of you tuned into the live webinar may download the slides now by clicking on the Event Resources section of your webinar screen. And if you are interested in the Certificate of Attendance option, look for instructions in the email you'll receive around an hour after the live broadcast. For those of you listening in replay or podcast mode, you can visit ADDitudeMag.com and search Podcast 360, that's 360, to access the slides, the webinar replay, and the Certificate of Attendance option. If you support the work we're doing here at ADDitude to strengthen the ADHD community, we encourage you to visit ADDitudeMag.com/subscribe and sign up for ADDitude Magazine for your family or to share with a teacher or a loved one who could benefit from greater understanding of ADHD. Now for today's topic. Did you know that 75% of people with ADHD have at least one coexisting psychiatric diagnosis alongside ADHD? In fact, 60% of people with ADHD have two or more comorbid conditions. ADHD's most common travel companions are depression, anxiety in adults, and oppositional defiant disorder in children and adolescents, particularly. The American Academy of Pediatrics and the Society for Developmental and Behavioral Pediatrics are leading the charge with new diagnostic and treatment guidelines for comorbid complex ADHD that factor in the importance of addressing not only core symptoms of ADHD, but these common coexisting conditions simultaneously. Dr. Cerulli will give us a fresh look at diagnosing and treating the whole person. Dr. Cerulli is a graduate of Tufts University, University of Massachusetts Medical School, Harvard Longwood Residency Program in Adult Psychiatry, and Harvard Fellowships in Medical Psychiatry and Neuropsychiatry. Dr. Cerulli is board certified in psychiatry and is on the faculty at Beth Israel Deaconess Medical Center in Boston and the Neuroscience Education Institute. You can ask questions of Dr. Cerulli during her presentation, and we will try to get to as many of them as we can after she is done. So with all that being said, I'll turn it over to Theresa. Thanks so much for being here today.
Thanks so much for inviting me to be with all of you today, this afternoon here in Boston, and morning for many of you dialing in from other parts of the country. So welcome. Very much appreciate you spending your time with me today as well. I am here to share with you a topic that's dear to my heart on ADHD and coexisting conditions. I am speaking to you not just as a neuropsychiatrist who practices in this field, but as a mom of a child who has ADHD and falls into what we'll call this complex category of ADHD. So again, a topic near and dear to my heart. My hope is to be able to share the clinical information, and by the end of this presentation, it's about 30 slides that we'll have together, that you'll have 20 minutes or so to ask questions. Happy to share with you information that I have learned over the years, both personally and professionally in this field. So we're starting here with ADHD and coexisting psychiatric conditions. ADHD exists alone only about 25% of the time. Most of the time, there are other psychiatric conditions, what we call coexisting or comorbid conditions, that travel along with ADHD. I have a colleague, Frank Lopez, who works and practices in Florida, who says he calls them the frenemies of ADHD, the friends and enemies, the things that tend to travel with ADHD and often can complicate the diagnosis and treatment management. ADHD with one coexisting condition, that happens about 15% of the time, and ADHD plus two or more, believe it or not, coexisting conditions happens 60% of the time or so. So most of the time when you're either being evaluated for ADHD or you're a clinician practicing in this field, you want to be thinking about this pie chart that really only it's more less common, I'll say, to have just the core symptoms of ADHD alone. When I first started in this field, now 20 plus years ago, I had some colleagues say to me, "You're specializing in ADHD, Theresa. What, seeing the same patients all day long, don't you get bored with that?" And I kind of chuckled, because long before this pie chart was available, I was clear in my practice that I am not just seeing ADHD when I'm working with ADHD patients. I am really seeing very, very interesting and passionate group of patients, kids, adolescents, and adults with these complex situations. And it's often tough to sort through what is just ADHD and what else is going on. So I absolutely love this field and love practicing clinically and teaching. So moving on to more about this topic, what are some of the common coexisting conditions? Well, in kids, it's a little different than with adults. We know this. Children, you tend to see more of the comorbid oppositional defiant disorder, kind of conduct disorder, tic disorders, which travel with ADHD upwards of, or I should say up to about 8% of the time. So that there seems to be some underlying, perhaps genetic predisposition to both conditions, that having tics and ADHD. Tics tend to peak around age 10 and 11 and then tend to resolve over time as one goes into later adolescence and adulthood. And the other thing that kids might present with as a coexisting condition with ADHD is a lot of anxiety. We see that quite a bit in clinical practice. How about adults? There are also comorbid conditions, but they look a little bit different. It's often more depression and anxiety are probably the top two we see, but sometimes even bipolar disorder can coexist with ADHD, and that's a tough differential diagnosis to make because a lot of the symptoms overlap with one another between ADHD and bipolar. And then finally, substance use disorder, something we really struggle to both diagnose and treat, that commonly co-occurs with ADHD in adults. The next slide is more specific. If we break it down by age groups, what are the common comorbidities and how do they change with age? The 6 to 12-year-olds on this slide are represented in the blue. The 13 to 18-year-olds are represented in the teal color. And finally, the adults age 18 and above are represented in the pink. And you'll see with the conditions that are most common in the kids and adolescents, it's more the oppositional defiant disorder, conduct disorder. And then by adolescence, you're seeing that anxiety, the pink, start to really increase into adult years, right? The pink group is the above 18-year-olds. And then finally in adults, by the time one is well into their adulthood, it's the depression and substance use and anxiety that are really the top three that stand out for people. So it does shift with what the frenemies are, depending on what age group you fall in to. This is a constant reevaluation throughout so when one's diagnosed with ADHD, it's a constant reevaluation with what else is going on throughout one's lifetime. What about untreated ADHD? I don't mean to be sounding like the wet blanket here, but I do want to point out that this is a prevalent condition. It's a persistent condition into adulthood for most people. And it's serious in that untreated ADHD really does bring higher rates of these comorbid psychiatric conditions, injuries, academic issues, occupational issues, relationship issues. So it's nothing to just, I think in some ways people think of it as a secondary, problem. Somebody's just having problems with attention. It's just a problem in school. It's a lot more than that. It's actually kind of a dangerous condition if untreated. What do I mean by that? Well, not only do the morbidity rates, meaning the sort of negative outcomes, go up, but so do the mortality rates. And it's something you don't hear this often, but we have the data that really shows there is actual risk of even death in individuals with ADHD untreated, mostly due to accidents. I mean, picture, again, inattention, difficulty with sustained attention to detail, and impulse control issues behind the wheel of a car, say, right? Driving data with ADHD. It can be risky. So simple ADHD, which on that last slide, we looked at the pie chart, remember, only exists about 20% of the time when there's none of these comorbidities. Just plain simple core symptoms of ADHD imparts a higher mortality rate of about 2 times greater than in individuals without ADHD. And that's usually things like accidents, some kind of trauma. Occasionally, we even see some elevation in suicide rates. So simple ADHD already imparts some problems. How about comorbid ADHD? Well, comorbid ADHD, it's actually a 5 times greater risk of all-cause mortality compared to simple ADHD. So we really do want to start to pay attention to, and no pun intended there, to the comorbid conditions, not just the core features of ADHD. So what is ADHD versus comorbid complex ADHD? It's comorbid complex is not a term I'm making up. It's coming from some evolution in our thinking and understanding with diagnosis and treatment guidelines, which I'm about to get to momentarily. Okay, so simple ADHD was defined as it has been many years in the DSM, the Diagnostic and Statistic Manual that we use in psychiatry. It's kind of like our Bible. The symptoms of inattention, this is probably very familiar to you, there are 9 symptom domains in the inattentive category, things like difficulty sustaining attention in tasks, losing things, being easily distracted by stimuli and noises around you, having trouble following through or listening when spoken to directly. How about the inattentive hyperactive symptoms? Also from the DSM. DSM-5 is the version we're now using. It came out in 2013. There are 9 hyperactive impulsive symptom domains, just like there are 9 inattentive symptom domains. What are some of these? Well, fidgetiness, trouble remaining seated when one needs to, and a kid that might be in the classroom, adult that might be sitting through meetings, through religious events, talking excessively, blurting things out, having trouble just in leisure activity, being kind of quiet, calm, very restless. That's the hyperactive impulsive category of symptoms. Doesn't mean everybody has the hyperactive impulsive symptoms. Let me be clear. You can have predominantly inattentive type ADHD or predominantly hyperactive impulsive subtype of ADHD or combined type, which is the more common presentation for ADHD, where people have features of both inattentive and hyperactive impulsive symptoms. So further defining what's in the DSM for criteria of ADHD, it's not just those symptom domains that we just talked about, but it's the presentation, when the presentation of symptoms occurs, that matters. And really, most people, symptoms have to have been present before age 12. In other words, you can't just develop ADHD in adulthood. That symptomatology, even if you weren't diagnosed until you were an adult, the symptomatology really was there in childhood, and most of the time by criteria before age 12. The symptoms also have to be in 2 or more settings, home, school, work. In other words, if the symptoms are only presenting in one setting and the individual is struggling just in that setting, you may want to rethink the diagnosis, because chances are there's something else about that circumstance for the individual that's driving the inattention, not the neurobiological ADHD, but something external. So 2 or more symptoms, that's part of the criteria, 2 or more areas, that's part of the criteria. And also the quality of functioning. In other words, it has to be impairing. You can have lots of inattentive symptoms and lots of hyperactive impulsive symptoms on that list I just gave you, and still not meet the full criteria if they're not impairing. Impairment is part of the definition of and the diagnosis per DSM. So, and then of course the symptoms can't be accounted for by another diagnosis. Why do I say that? Think about I'm going to give you an analogy in primary care settings. If you go in to see your doctor with a fever, the fever is a symptom. You still have to look for all of it's a sign, actually, if I want to be specific. Signs and symptoms have slightly different terminology in medicine, but let's say it's a symptom. You still have to look for all of the underlying possibilities of what's causing the fever. The fever itself isn't the diagnosis. And that's how I think about inattention. People come in saying all the time, I can't pay attention in school, or I'm having trouble paying attention at work, and I get overwhelmed. And so I think I have ADHD. Well, you have to look at all of the other things that can cause people to struggle with attention and concentration. And there are many. So the inattention is just a symptom. It's not a diagnosis. Okay, how about kids versus adults? There's slightly different ways, even within the DSM, that we look at this. Of the 9 inattentive symptoms, I'll go back 2 slides just to remind you what those were. Those are the 9. You need at least 6 of the 9 inattentive symptoms and at least 6 of the 9 hyperactive impulsive symptoms to meet criteria for combined diagnosis of ADHD in kids and adolescents age 16 and under. So 6 of the 9 symptoms for inattention, 6 of the 9 for hyperactive impulsive, and 6 of the 9 hyperactive impulsive symptoms to meet criteria if you are age 16 or under. How about the adults? And notice here in my highlights, the adults are defined as age 17 and up, interestingly, in at least for this category in the DSM-5. At least 5 of the inattentive symptoms and our hyperactive and impulsive symptoms, not 6. Why? Why did that change with the DSM-5 that we're a little bit more lenient on the number of symptoms? And it's because the adults don't present necessarily with the full spectrum in the same way that the kiddos and adolescents do for ADHD. So we've loosened up the criteria a bit in the 17-year age group and up, and that's both in the inattentive and hyperactive impulsive symptom domains. So that's our core ADHD, our simple ADHD diagnostic criteria that has been around for many, many years. But what about all these other associated symptoms? So I tried to break out by color what I mean by core features versus associated symptoms. ADHD core symptoms, there are 3: inattention, hyperactivity, and impulsivity. So our DSM, our diagnostic manual of the core features of ADHD, fall into those 3 areas. The associated symptoms are things like you can have traits of autism, behavioral dysregulation. We know learning disabilities co-occur about 20% of the time with ADHD. Note, ADHD itself is not a learning disability. Most people with ADHD are above average intelligence, can be extremely bright, in fact. This is not about IQ, it's about attention. It's a medical condition. Learning disabilities are not considered medical conditions because you don't treat a learning disability with medication per se. And it's more about the repetition for specific reading. For example, if there's a disorder with dyslexia, reading, you'd be remediating the problem in a very different way. It's not a medical condition per se. Emotional dysregulation often goes hand in hand with ADHD as an associated symptom. Psychosocial symptoms, and of course, sleep issues, very, very common. So none of the things in the green are diagnostic of ADHD because they can exist with many other conditions, right? These are not specific to ADHD, but they often do travel along with ADHD. The blue, again, is the core symptomatology of ADHD. So why do people with ADHD have such different presentations? Back to my original comment when I said I work mostly with ADHD patients, and that's my area of interest, and my colleagues saying, but don't you get bored doing the same thing all day long? And the answer is absolutely no. Every single person I work with is different. There's a strong heterogeneity to how ADHD presents from one person to the other. You can have someone with the predominantly hyperactive impulsive symptoms that has a real tough time staying seated. They're restless, they're fidgety, they're bouncing their leg when you're talking to them. And they're chatty. And then you can have the exact opposite, somebody with the more inattentive symptoms who has absolutely no behavioral dysregulation whatsoever, or physical movements that one can see, but yet they're daydreaming and staring out the window and didn't hear anything you just said. So very, very, very heterogeneous presentation. Why? Why are some of the core symptoms different from person to person, and why are some of the associated symptoms different from person to person? I'm a neuropsychiatrist by training, so the brain to me is the most fascinating, sexiest organ in the body. So drawn to this topic. ADHD is very much brain-based. We know that there's differences in neuroanatomy, in genetic links with ADHD. It's one of the most highly heritable conditions. It's about as heritable as height. There's differences in the neural networks. In other words, how different parts of the brain talk to one another with folks with ADHD versus without ADHD. And then finally, even the neurotransmitter shifts, the little messengers in the brain that talk to one another. Also, there are some differences in ADHD versus non-ADHD. So very much a brain-based condition. And before I had a daughter in this field, my daughter didn't exist when I was practicing in my fellowship years. I did a fellowship in medical psychiatry and then neuropsychiatry, and I became fascinated with the condition based just on the things we're talking about right now. It wasn't until, as life's ironies often have it, many years later when my daughter was born, that she actually has ADHD. It's from her dad's side of the family. I think I'm more of the OCD category if we had to pick one for me. So differences in understanding the science of complex ADHD, meaning the reason this is so heterogeneous and the reason people have different associated features has a lot to do with what parts of the brain are involved and get impacted. So next slide. I do not mean to make this a lesson in which you're memorizing terms you will never need to hear or know again, but to let you know there really is a lot of thought behind when we talk about neurobiological differences, even just neuroanatomical changes, like literally structure in the brain. And pretty neat, a lot of the changes and differences happen in the what we call prefrontal cortex, the kind of the forehead slap. It's right here, the front part of the brain, where different areas are involved in different aspects of ADHD. I told you the core features are inattention, hyperactivity, impulsivity. I'm going to add that sometimes that impulsivity is actually not just a physical impulsivity, but sometimes an emotional impulsivity. So inattention, hyperactivity, impulsivity, and sometimes emotional impulsivity, quick to react to things, just like quick to react with in terms of muscle, motor movements. So let's look at the parts of the brain in that prefrontal cortex in the front. And I'm going to say that the green area, which is called the dorsolateral prefrontal cortex, that's involved very much in the, quote, attentional part of this condition. Attention and thought, it's in this part of the brain, I call it, let's say, the chess center of the brain. If you were playing chess and moving your pieces on the board and having to plan ahead movements and think ahead what your opponent's going to do and come up with a strategy, this part of the brain in the prefrontal cortex in green is working really hard at that moment. It's very much involved in regulation of attention. How about the purple? The purple, the ventrolateral prefrontal cortex, is very much involved in the behavioral part of regulating. It's the purple area that is involved in inhibiting inappropriate responses. What do I mean by that? So you're the kid in the classroom, somebody just has been poking fun at you, they're giving you a hard time, and you turn around and punch the kid. You're having a hard time, you couldn't modulate your response well, and you react impulsively and behaviorally in a way that you might, if you thought it through, wish you hadn't done, but you're quick to react behaviorally. And notice that purple area, the little arrow where it's connecting to premotor areas of the brain, meaning areas that are involved in movement. So there we go. There's the behavioral. So attention was green, behavioral's purple. And now let's go on to impulse control in the pink area. We don't really always hear much about this piece, but it's so important in what I do in talking about comorbidities and complex ADHD. The emotional impulsivity that people experience, in other words, quick to react emotionally, not just physically when things happen, comes from this ventromedial part of the brain. And you'll notice some of its connections in often in other areas of the brain, often involved in that, in the areas that do have some emotional meaning. But this part, this pink part that's in the prefrontal cortex, has to do with the regulation of emotion. What do I mean by that? Let's take our friend in the classroom who was being, poked at, and his friends were giving him a little bit of a hard time, and he or she reacted strongly and took a swing at the person who was upsetting them. There's also the emotional regulation. They had trouble self-regulating emotion, saying something back at the same time, yelling, for example. That's not a mood problem. It's an ADHD problem, right? The mood state is appropriate. That person is really upset because somebody was saying things to them that were really upsetting. The mood is correct. We all have a right to get angry and moody and upset. especially when somebody's not treating us fairly. But the ability to regulate the emotion, to inhibit the response of wanting to punch the person next to you or say something back or swear, or that's coming from the frontal lobe that has to kick in and override the impulse. And in someone with ADHD, if you're struggling in that part of the area of the prefrontal cortex, it's really hard. It's not easy to just say, I know I'm not supposed to do it, but I did it anyway. It's hard to rein it in. So you can see why that condition can present quite heterogeneously, depending on which of these areas might have been impacted when you're talking about the genetic underpinnings of the condition. And when I talk about neural networks, if you notice the arrows that project from this area in the front part of the brain to all the other parts of the brain, so it depends on where the projections go, how those areas connect and talk to one another, that makes the this so different from person to person. Okay, next slide. So our guidelines have existed for a long time, basically about when I started in this field 20 years ago. But I will tell you the guidelines of how we understand, diagnose, and treat ADHD are continually evolving since then. So back in 2000, 2001, the American Academy of Pediatrics did put out their practice guidelines. The Diagnostic guidelines came out in 2000. The treatment guidelines from the American Academy of Pediatrics came out in 2001. It wasn't until 11 years later that we had any updates to the treatment guidelines, pretty incredibly. And at that point, what they did was sort of expand the age range. We knew that there wasn't always that at the time. The guidelines said age 7 and under, that you had to have been diagnosed with ADHD prior to age 7. Remember, what I told you in this presentation is it's prior to age 12 because the DSM-5 changed the age criteria compared to DSM-4. We figured out that not all symptoms, people particularly with inattentive symptoms, you may not have had picked up on that until a little older, into age 12 as opposed to age 7. So there was some changes, but now really within the last few years have been a significant shift in our evolution of thinking about how to diagnose and what are our practice guidelines. And it started here in September 2019 with the American Academy of Pediatrics updating their guidelines to include an action statement about the comorbidities. So more specifically, in 2009, this key action statement really wanted to expand past the core symptoms that we know, the inattention, hyperactive, impulsive symptoms that we've seen for years and years in the DSM criteria, and look at, but what about the 75% of people that have coexisting conditions, because it's the majority of people with ADHD. So the primary care clinician, if trained or experienced in diagnosing comorbid conditions, may go ahead and initiate treatment of such conditions. In other words, the emphasis is on here paying attention to the comorbidities. And then after detecting possible comorbid conditions, if the primary care physician or clinician is not trained in making the diagnosis or initiating treatments in the comorbid conditions, then patients really should be referred to a subspecialist who knows how to do so. There's a bit of an art and a science to this, especially if you're talking about medications, because sometimes when you treat one condition, you can worsen another if you're not careful about both diagnosis and treatment. So that's my next topic here. It's this fine balancing act, seesaw. I like this analogy with the seesaw because when you're talking about ADHD and comorbidities, if you just sort of jump off the seesaw, you're going to send the other person flying. And that's true with comorbid conditions. You really have to keep a constant balancing act of paying attention to what else is going on besides core symptoms of ADHD, and in concert addressing issues. You can't ignore one side of the seesaw. So treatment of ADHD may indeed, but by treating ADHD, I should say, if you just treat the core features of ADHD, you may indeed resolve and improve the coexisting conditions, such as the depression, anxiety. Particularly, let me give you an example of that. If you have someone who's really struggling in school academically because of their ADHD, and it's causing severe anxiety or depression as a secondary symptom because the ADHD has been so tough on the impact in terms of their academic performance and sometimes even their the attitudes toward the peers in the classroom or their teachers, that secondary depression or anxiety may get better on its own if you're treating the ADHD. But the comorbid condition, the depression, anxiety, may also require separate treatment in addition to the ADHD treatment. Both are so important to at least recognize before you can even decide about the treatment, but at least start to recognize that 75% of the time there is a comorbid condition. Besides the American Academy of Pediatric guidelines, we've seen updates in the Societal for Developmental and Behavioral Pediatric guidelines. This society followed suit after the American Academy of Pediatrics. So January 2020, remember the AAP, it was September of 2019. January of 2020, the Societal for Developmental and Behavioral Pediatrics came out with the guidelines as well. Rather than talking about comorbid ADHD, they just had a slightly different terminology. They're calling it complex ADHD in these guidelines, really talking about very similar things, which is why I entitled this presentation, or part of this presentation, is comorbid complex, because the terms are a little confusing, but they really are referring to mostly the same idea of expanding our understanding beyond core features of ADHD. So in the SDBP guidelines, what it says is the clinician with specialized training or expertise should go ahead and initiate a comprehensive assessment, multimodal treatment planning for any child or adolescent with the suspected or diagnosed complex ADHD, and should include evidence-based treatments, including for the coexisting condition. So we're seeing this evolution in the field and the powers that be to pay attention to the comorbid and complex case situations. And how do you define complex ADHD, which I've been calling comorbid, but the SD Societal for Developmental Behavioral Pediatrics is using the terminology complex ADHD, and this is how they define it. Patients that have the suspicion of coexisting disorders or known presence of coexisting disorders, so the comorbidities, that have moderate to severe functional impairment. Maybe the impairment isn't as severe as per the DSM criteria, but that it's impairing, and that there's some uncertainty diagnostically on the part of the primary care clinician, or treatment uncertainty among the primary care clinician. These are that's considered complex case. And then here we go, the age criteria. Actually, so even above age 12, we do sometimes see that patients haven't got the initial symptom presentation until later in life. Does that mean that they don't have ADHD? No. So you can, past age 12, start to still diagnose complex ADHD by age criteria. You probably don't make it all the way to adulthood without some symptom presentation, right? Again, you may not be diagnosed with ADHD until adulthood. Even I have some of my geriatric clients that weren't diagnosed until much later in life, but the symptomatology usually is there earlier on. Okay, so treatment paradigms. But I want you to think, I guess, if there's a take-home message for everyone listening today, it's that our treatment paradigm is shifting. The old school teaching was treat the comorbidity first. In other words, treat the depression first, treat the anxiety first, because then your ADHD might get better. And if it doesn't, then you can treat the ADHD. There's such a fear, I think, around even understanding and diagnosing ADHD that it was, well, do everything else first. And then if you still have a problem, then you can treat the ADHD. Our current approach is different. Now, what we're realizing, and I spent time on all those guidelines because this does come from after many years of the debates that go on before guidelines are updated with what we know in the field. So now the current approach is treat the comorbidities first only if they are severe. If you have someone who is severely depressed, needing inpatient hospitalization, or severely depressed and suicidal ideation, suicidal thoughts are there, clearly you need to address that before you can do anything else. Short of it being a severe comorbidity, you really want to instead look at the right side of the bottom part of my slide here, and you're going to approach this differently. You're going to treat simultaneously the ADHD and the comorbidities together. You're going to pay attention to the diagnosis on both of those, and you're going to treat and treat both simultaneously if trained. Again, obviously need someone who's got an expertise in doing this and comfort level in doing this. But I don't want you to stay with the old paradigm of you have to treat everything else first before you can address the ADHD. It's not part of our guidelines anymore. Next slide. So how do you evaluate ADHD? Again, there is an art and the science to this. We have the DSM core criteria. We have a lot of rating scales. So you want to establish the diagnosis using what we know. There's also a lot of adjunctive things you can do so pieces of neuropsych testing, continuous performance tests on the computer to see how one sustains attention over time. There's some supportive things you can do, but and certainly rating scales, which we'll get to in a moment. But the core features of diagnosing ADHD from the DSM, you've already seen that again in today's presentation. Those are the core features, and how one meets DSM criteria is that 5 of the 9, if you're age 17 or above, 5 of the 9 inattentive and 5 of the 9 hyperactive impulsive symptomatology. If you're age 16 or under, it's 6 of the 9. There's your diagnostic gold standard, meet with your doctor, diagnostic evaluation and criteria for ADHD. How about step 2? You have to rule out all the other reasons why somebody may be having this symptom presentation. So for example, I had talked about fever. Remember, it's not a diagnosis, it's a symptom. So when you're even if you meet DSM criteria, you have to look at all the other reasons somebody may be meeting the criteria. Maybe they are, there's a family changes at home. The family's going through a divorce, and there's a lot of the problems paying attention and behavioral dysregulation are related to the circumstances in that person's life. Maybe they have a sleep disorder, and it's awfully hard to pay attention and have good self-control and regulation and feel good self-regulation of behavior if you are not sleeping. I take sleep very seriously and in terms of all of its side effects if you're not getting enough. So step 2 is to make sure we're not missing something else. And then 3, making sure to assess for comorbid conditions. In other words, even if you've made the diagnosis of ADHD and you're 100% clear that is what you're looking at, remember 75% of the time there's a comorbid condition. 15% of the time it's one comorbid condition. 60% of the time it's 2 or more comorbid or coexisting conditions, that complex situation. So making sure to assess for that as well. Okay, so here are some of the diagnostic rating scales. This is for your reference later. We won't go through these painfully one by one, but know that when I'm practicing, I don't just administer the ADHD rating scales, the things that we're doing to collect information to learn about you or your child with ADHD symptomatology, but also collecting information on some of the comorbidities simultaneously. Depression scales, mood scales, anxiety scales, social responsiveness scales. These are other pieces of information that are really important for us to know to be able to help our patients. The next slide is how I look at I call it setting the treatment table for success. It's all of these pieces. People often say to me, well, it's just about, I want to try everything but medications. I'm not for medications. Or the opposite, I don't have time to do the therapy. I just need to take medications. Or I want to work with a ADD coach. All the above are important. I really think of this as balancing the table. 4 legs of the table here. They're support legs to the table, the patient sitting on top of the table, and or family of the patient, because this really is a systems issue. For here I am volunteering that I know what it looks like in our household, and all of us are participating in what goes on in this household and the outcomes. So it's patient and family, I would say. The supports have to be equal. If you have one short leg on the table, it rocks. So what are those 4 legs of support? Sturdy, hopefully, legs of support. The pharmacotherapy is one piece. It is important to talk to your doctor about medications, the pros, cons, the options, at least get information on that piece. Accommodations in school or workplace, also very, very important. We think about the neuropsych testing, if you do it, it's not as important diagnostically as it is to be able to make recommendations of what kinds of accommodations are helpful for that individual. Because it's such a heterogeneous condition, you cannot have a one-size-fits-all recommendation to the school on what accommodations to make. So neuropsych testing, I would argue, is not as important in making the diagnosis of ADHD. It's in learning about all the other ways in which that individual learns. So learning disabilities that might be there or not be there, the way somebody takes in and processes information, that's important in making accommodations for this student. ADD coaching, important in adolescents and adults. In kids, the younger kids, I'll call it parent training. You're really coaching the parents to coach the kids. So ADD coaching is not a therapy model. It's a sort of hands-on, how are we going to learn to pack the backpack for the kids, how you're going to learn to organize and manage your schedule, a calendar. It's that kind of nuts and bolts approach to, and a lot of the coaches come from sort of a business background or maybe from an educational background. They're not therapists. Then finally, the psychotherapy, my fourth leg of the table here, also extremely important. The therapist plays a role in helping the person around figuring out how are we going to manage the coexisting depression or anxiety or sleep issues that have developed, right? There's so many of the other things we're talking about that are there 75% of the time. And the family therapy, it may be individual therapy or it may be family therapy because this is a family systems issue. It does not exist just in the person. It's the whole picture that's important. And pharmacotherapies, there should be at least one slide because it's one leg of the table, what we mean by that. So I think of the kind of baskets of treatment options. There are stimulant medications that have been around for many, many years. The methylphenidates, which is the Ritalin type medications. There are many short-acting, there are long-acting versions of those. They've been out since the 1950s. The amphetamine type stimulant medications have been out since, believe it or not, the 1930s. So there is a very long history with this category of medications. I put just below the bullets here, I put the prodrug Vyvanse in its own category because it's an amphetamine base to that type stimulant, but it's a prodrug formulation without going into all of the history on that. The attempt was made by the manufacturer to have it FDA approved as actually a non-stimulant because it's a prodrug. The parent molecule itself is not active. It's not until the molecule is split in the bloodstream that it becomes an active amphetamine. So it's a little different formulation, so I put it under the stimulant category because it is a stimulant, but it's a little bit different version of one, at least in the parent molecule itself. The non-stimulants, we've had several FDA approved over the years. There are some non-FDA approved ones we use, what we call off-label, but the FDA approved ones, some of them are Strattera, Intuitive, and Capvey are the three that come to mind initially. Now, however, there's a newly FDA approved non-controlled substance, non-scheduled substance called Qelbree. I'm going to say it again because people keep mispronouncing it. It's written with a Q, but it's actually pronounced like it's a K, Qelbree. And this is just been approved in April of this year. So kind of hot off the presses information that there's a novel agent that's non-scheduled as well. And we are approaching our final couple slides here. So you don't have to get fancy with measuring outcomes. I encourage all of you, whether you're a healthcare provider on the line or somebody seeing a healthcare provider, you can do this very easily without fancy apps or the diagnostic rating scale list I gave you. And that's set your own 5 goals on what symptoms you want to see targeting to improve. Because it's such a heterogeneous condition, those 5 symptoms you want to improve on will look very different from person to person. And what goals you want to achieve are going to look different from person to person. Set your own scale, 1 to 10. And on each of those 5 items, 5 goals, and each of the 5 symptoms, you want your goals going up on the ladder, and you want the numbers of symptoms going down on the ladder. So again, give yourself 5 categories of goals, 5 categories of symptoms, and monitor over time, are you going up or down on the ladder? Very simple, but it does help you know from time, because sometimes it's hard to forget when we initiate treatment where we've come from and how far we've actually gone. What things looked like when you first walked through the door might not always be so clear 10 months later or 2 years later. Okay, finally, our summary slide. 75%, what did we learn today? 75% of patients with ADHD have at least one coexisting condition, and 60% will have 2 or more coexisting conditions. And this does increase the risks with morbidity, and I dare to say it, even mortality. Remember that complex ADHD, comorbid ADHD, was 5 times greater risk of mortality than simple ADHD. So we need to be paying attention to these coexisting conditions as much as the core features of ADHD themselves. Those comorbid conditions can shift with age in the way they present. Remember, kids and adults will be different in that. Kids more the oppositional defiant symptoms, conduct disorder, anxiety. Adults, much more the depression, anxiety, and substance use. Adolescents as well, adolescents and adults. Those numbers go up. The guidelines have changed and evolved in both the AAP and SDBP to emphasize the importance of the comorbidity. I explained to you a little bit about the neurobiology, not to have you painfully trying to remember or take notes about the details of the where in the brain and the genetics, but just to give you a sense of this is why there's such different symptom presentations from person to person. And then finally, our treatments for ADHD. Now, the new paradigm is really to look at both the ADHD itself and the comorbidities in concert to improve and have the best outcomes for ourselves, our loved ones, and for our patients. With that, I think we can go ahead and move to questions.
We have plenty of good ones, so thanks so much. It was excellent, really an excellent presentation. Someone is asking, is ADHD more likely to be inherited along the maternal or paternal lines, or both equally? Or are there any studies on that?
Yeah, so both equally is the answer as far as we know. There hasn't been a breakdown from maternal versus paternal side, but it's clear that it is highly heritable. People also sometimes ask which genes are involved. There are some that have been, we'll call them candidate genes that have been identified that seem to travel and commonly occur in folks with ADHD, but it is still quite different from person to person. So the heritability is, to be exact, the heritability factor is 0.77, which means that 77% of the time, if you've been diagnosed with ADHD, it's because of the genes you're carrying as opposed to the something else. About as heritable as height.
Mm-hmm. Is the diagnostic approach different for men versus women? I mean, you outlined various things and the way ADHD diagnosis is handled. Are there differentiations to be made with women?
So the ratios, let me start with that because I think that the presentation, remember we talked about the heterogeneity, that a lot of the women and girls will tend to present, overgeneralization on my part, but will tend to present more with the inattentive symptoms and sometimes less of the hyperactive impulsive symptoms. And I do honestly mean that's an overgeneralization because you can have both, whether you're male or female. But where I get that from is that when I first started in this field, the ratio of boys to girls was 9-1. In other words, it looked like boys had this condition more often. The ratio now, boys to girls, is 3-1. Nothing changed except our understanding and our ability to diagnose the girls. That's what changed. And it was because the girls weren't presenting as much with the observable symptoms in the classroom, the hyperactive and impulsive symptoms. If you've got those, the teacher's going to pick up on it, right? The parent is going to pick up on it. The girls that are the daydreaming, staring out the window, inattention, not necessarily going to fall on someone's radar as fast. So we're just doing, I think, a better job of identifying it in the girls. By the time someone reaches adulthood, the ratio of men to women is 1-1. So either we're doing a much better job by adulthood in identifying the features such that there are the ability to diagnose is getting much better with time, or it's the fact that the hyperactive impulsive symptoms do improve with age, even if you had them in childhood on their own. So the symptom presentation by adulthood in most people is going to be a lot more of the cognitive aspects of ADHD, if that helps.
Mm-hmm.
So there are differences in the way the symptomatology presents, and you can go back and think about that prefrontal cortex and perhaps why genetically that might be. But there's I can't say, geez, the genes are X-linked, X chromosome linked, and therefore, more likely to occur in women. It's or Y-linked and more likely to occur in men. It's not like that. That there's not an identifiable difference, genetically in terms of why someone's male or female, and linked to ADHD.
Right. You mentioned in one of the slides the autism traits associated with ADHD. Several people wanted to know what those would be.
So when I talked about learning disabilities and said that they're not treatable with medications, but ADHD is treatable with medications, it's the kind of the distinction between in medicine, what we call sort of axis 1 versus axis 2 diagnostically. The axis 2 type disorders we don't treat with medication. So learning disabilities fall into that axis 2, as does autism. But there's some traits that go along with autism that go along with ADHD that can be present. In other words, you can have both autistic traits and ADHD, or it may be that the autism symptoms are presenting with some of the behavioral dysregulation that you can see with ADHD. So I don't mean to confuse anyone, but know that the conditions can coexist. They can look like each other sometimes, or one may be diagnosed mistakenly for the other, or vice versa, because there is some symptom overlap. So some of the behavioral people with autism, sometimes when I will say when it comes to treatment, the stimulant medications can often worsen some of the symptomatology that you can see, as opposed to with ADHD, you're hoping the stimulant medication will improve symptoms. But flatness or some of the emotional dysregulation can get worse in someone with autistic traits with their ADHD. So you have to be careful in terms of a treatment approach to make sure you're really identifying which is which diagnostically, and or both.
Right. As with almost all of our webinars, people ask, can you recommend sources of information or directories where people can find clinicians with experience in ADHD or comorbidities? Do you have any recommendations for them?
That's a tough one from the clinical side, other than I will say this, one of the nice things that's happened with telehealth is access to a lot of the ADD coaches. That because there are fewer of those, there are certain certification programs with ADD coaching. So certainly when you're talking about specific clinicians, it used to be hard to find coaches to refer to. Now, because a lot of them are doing telehealth, it's become easier. When you look at like New England Coaching Academy, there are these certification programs that are helping to train coaches, and there are coaches now available online, so that regardless of what part of the country you're in, these folks available to help. I have seen, not that I mean that they're diagnosing the condition, but a lot of the folks that start, if you're struggling with time management, organization, planning, executive functioning, a lot of these pieces that go along with ADHD, the number one treatment is to refer to the coaches, that fourth leg of the table that we're talking about. And the coaches will often then tell you who in their area is really good diagnostically with ADHD. So the coach isn't diagnosing, but they're often a good resource for who in their area to refer to.
Right.
That's one inroad, because they're so subspecialized. A lot of us, even so I'm a neuropsychiatrist. There's very few neuropsychiatrists. You're not going to find that. And not all neuropsychiatrists are particularly specialists in ADHD either. But so you've probably all heard CHAD is a wonderful organization if you're looking for resources on the child adolescent side. ADDA, the Adult Attention Deficit Disorder Association, a wonderful resource on the adult side. On my website, I've posted a number of websites. There are also links to helpful websites and resources. I was part of Team ADHD. There's more to ADHD.com as a non-branded website, fully materials on ADHD. So there's a lot out there. Word of mouth, number one, though. Honestly, in your area, to find someone in your area, word of mouth is number one. If you go to your pediatrician and who's your go-to person for ADHD. But yeah, telehealth has opened an awful lot of possibilities. Most of us are practicing online, seeing folks around the country now.
Mm-hmm. Several people have asked, how do you distinguish bipolar disorder from ADHD? They have had trouble making a clean diagnosis on one or the other.
Yeah, it is. I'm glad you brought that up. I spent a lot of time on that slide with the prefrontal cortex, and remember the pink area that was that emotional impulsivity. So clinicians have trouble with this. So having somebody who is specialized does help when it comes to this level of diagnostic differentiation is tough. For someone like me, I mean, the number one thing I would say is there is a difference between bipolar. The mood state itself is off. You wake up and on the wrong side of the bed. There's this kind of chronic irritability. You don't even necessarily know why. Sometimes the mood swings are I don't say unpredictable. There's not always a stimulus to why somebody's having a rough day. And the rough day can come in waves or days often of symptomatology. They're episodic. That's more bipolar. And in kids, you call them affective. Affect is kind of the way somebody's mood presents. Affective dysregulation over long periods of time, affective storms. So it's not just in reaction to a given stimulus. Whereas ADHD, that pink area, that emotional impulsivity, think of it, another word I'd substitute is reactivity with ADHD. The mood state is appropriate. The person is appropriately upset. Something just upset them. Mm-hmm. The road rage adult. That's not bipolar when somebody reacts. It's the quick reactions physically and emotionally to something that was just upsetting, but the mood is correct.
Right.
They're angry for a reason. It's tough to modulate. It's what we call a top-down thing in the brain. I'm a neuropsychiatrist, so I have to talk about the brain. The top-down, meaning from the frontal lobe down, it's trouble modulating the mood state. The mood state is correct in ADHD. The ability to modulate it and respond without causing yourself problems or consequences is what's hard. Bipolar is different. It's a bottom-up. The mood state itself is a bit off. And it's not necessarily correlating to an event.
Right. That's very interesting insight, really. That opens up some different thinking for me on that. Do you have any thoughts on rejection sensitivity dysphoria as a comorbidity with ADHD? A lot of people have brought that up.
Yeah, it's I put it in when you think about associated features, because it's not diagnostic in and of itself with ADHD, but yeah, in other words, there are many different conditions that could be associated with rejection sensitivity, right? But one can understand, particularly if with any condition, most of the time you're hearing what you're doing wrong, if somebody's constantly correcting your behavior, if you're chronically being faulted that you don't care, that you're not paying attention to something that's really important, whether it's the teacher or the parent that's talking, or an adult, the workplace, your coworkers. If you're constantly hearing that, why wouldn't you have some rejection sensitivity, right? It's a natural struggle for people. And some of my most successful adults, and I will tell you that the ability to treat this it's so rewarding. Because when somebody is doing well and that table is balanced, right, people can excel. This is not necessarily a negative condition to have. People can be really creative and entrepreneurial. And so I work with a lot of very successful adults. But that rejection sensitivity, it's amazing what childhood traumas can do and damage for life. There's this sense of it being an imposter, even when one's successful, because you don't get to enjoy your own strengths if you've constantly heard when you were what you did wrong. So it's really it's so rewarding though, because when treated and managed, so I'll use my own daughter. My daughter she would have been somebody who, she's definitely got complex. She's sort of a combination of ADHD, anxiety, has been treated since she was, I think it was between first and second grade. And believe me, as a mom, I was a nervous wreck when somebody does tell you, geez, you might want to try medications, and here's what else went along with it. We did everything at the same time. But I can tell you the outcomes, her life might have looked quite different had we not reached out and found specialists and been really open to hear what everyone had to say. School doesn't have to be so hard. If you're an intelligent person that's just struggling with attention, and you can manage the attention and excel and really hyper even focused. People misunderstand that ADHD is about inattention. It's a variability in attention, trouble self-regulating attention. But if there's a topic you're passionate about and interested in, you can hyper focus on it and excel in an area that really interests you. So it's really, it's about managing it. This is not meant to be, when I talk about morbidity and mortality, it's that's if you don't treat it and you don't learn about how to best manage and train your brain to be able to pick things in life and circumstances that are a good fit for the way you're wired. All of us have to figure that out, regardless of what conditions we have.
Right. Well, I think the hour is up, Theresa. So thanks so much for being here and sharing your expertise. Really was excellent. Very insightful stuff.
My pleasure. Thanks for the invite. I hope everyone has a wonderful afternoon and summer. Take care.
And thanks to all of the attendees for joining us. Please join us next week when Michelle Novotny will discuss creating healthy habits and how to make them stick. And make sure you don't miss future ADDitude webinars, ADHD expert articles, or important research updates by signing up to receive our free email newsletters at attitudemag.com/newsletters. Thanks everyone for being here and have a great day.
Thank you.